Hey, good morning, everyone. My name is Morgan. I'm a nurse practitioner. I'm so excited to get started here today. Before we get going, I just wanted to let you all know that we have our 3-day live intensive review. This is a great way just to get everything in there before your exam. So it's coming at you May 31st through June 2nd. It's going to be all of us taking turns, different topics to just kind of give you a complete comprehensive review for your boards exam. It's $50. It includes all 3 days. You'll have 30-day access to the recording. And then it will be live, so you can ask questions and then go back and rewatch anything else that you want. And this is just such a good way to just take it all in right before you set up for your exam. All right. So just before we dive in today, I just wanted to let you know what we're going to be talking about. So our topic this morning is respiratory. We are going to not be able to cover everything. Of course, we can't do it all in just 1 hour, but we're going to go over those really important topics, okay? Before we get started, I just want to, remind you this is stuff that you know. This is just a review. You're going to do great, and boards is on its way. And before you sit and take your test, I just tell everybody, take a slow, deep breath a few times in and out, and just remember, you know these questions, okay? You know the answers to these questions. None of this is new. It's all a review, so you got this. Okay, this morning we're going to talk about the respiratory system, okay? We're going to talk about our exam findings. We'll talk a little bit about COVID. I bet you guys are all experts, being that you're coming out of school right now, and that evidence is completely, constantly changing as we're learning more and more about it. We'll go into a little bit of pneumonia, how this is important, also pulmonary emboli and how to see it, what to do. This is an emergency. Pertussis, the whooping cough, and also just like your upper respiratory infection, those still exist. Some people forget that. So a lot of my patients come in and they forget it's possible that we just have kind of your common cold. All right. So next we're going to talk a little bit about our assessment. So when we are putting our stethoscope on somebody's chest, what is it that we are hearing and what does it mean? So this takes a little bit of time. So I always tell people when you're learning lung sounds, they're pretty nuanced, and there's not a whole lot of change between some of these sounds, and it can take a while to really learn and appreciate the differences in some of these things. So practice. Whenever you have a patient sitting in front of you, please do that full exam where you're putting your stethoscope on all lung areas to really familiarize yourself with what is normal. So anytime that we have a really good understanding of normal, anytime we hear something else, maybe we don't know exactly what it is, but at least it cues us into something is not going on that as what we expect. All right, so we're going to start with kind of the most common here, which is our rails, also known as crackles. I think a lot about this sound kind of being something that is kind of the reason why we're hearing this sound. So we have both fine and coarse crackles. So the fine crackles are kind of short, they're high pitched, kind of pops. So I think of your Rice Krispies when you pour milk on Rice Krispies and you're hearing that popping sound, while the coarse crackles tend to be a little bit lower in pitch and they last a little bit longer, more like your fireplace. So when you hear these rails or crackles, we start to feel like there might be some rattling, clicking, bubbling noises. They're heard mostly on inspiration. And what they're telling us is that there's some airflow impairment throughout the lungs. Most often, we're going to find these in the bases of the lungs. So those lower lobes, getting down on the back pretty low is the most common area that starts to first show signs, and then it can kind of move up as a disease progresses or an illness progresses. Our most common things that we think of when we hear crackles or rails is pneumonia, maybe some bronchitis, pulmonary edema at the early stages, or even chronic conditions like COPD. Somebody might have just some fluid in there kind of all the time. Okay. And then right here, normal. Most important thing, this was on the exam. Sorry, I should have started here, is the vesicular sound. So that is just your clear, soft, low pitched in and out. And that's what I'm saying. Just listen so you can hear and this and really get your baseline of what a normal lung sound is in all different areas. Okay. Next, we're going to move to rhonchi. Okay. That's over here. That's really associated with just some congestion. So when we hear this sound, it's a low pitch, kind of a snoring sound. I think that they're kind of the easiest probably to pick up on as you're learning. And we hear them oftentimes in people who are congested. I think of kind of your larger airways, somebody who's just not feeling real good. We can have some inflammatory conditions, maybe pneumonia. Cystic fibrosis, we'll often hear a little bit of rhonchi when we're listening to the lungs of somebody with CF. And then, and so it's just something to kind of think about when we have a lot of like mucus that's just kind of plugging us up. Okay. Next over this wheeze. So when we think about wheezes, we think about a high pitched sound. This is when air is trying to fit through a narrowed space. Okay. So I think of inflamed airways. We think of this oftentimes with asthma because of that hindered airflow. So air is not able to move because we have some inflammation in the airway. So a high pitch sound, oftentimes inspiratory, expiratory, those both make a difference in kind of how worried we are. If we're having inspiratory, it's okay. If we're having expiratory wheeze as well, we start getting really worried about the possibility of respiratory failure in these kiddos or adults, I suppose, as well. But I just think of air trying to fit through a really constricted or tight space. However, if you hear this in the upper, so a wheeze in the upper airway here, more towards the neck, we actually changed the name from wheeze over to stridor. However, they're very much the same etiology, which is just kind of inflammation and air moving through a tightened space. So in stridor, we think more of the tonsils being really, really swollen, or potentially somebody who is choked on something that's causing the upper airway to have some inflammation. All right, croup can happen. Also, things like smoke inhalation. So if you're seeing somebody after they've been exposed to a lot of smoke, they may have a little bit of that upper airway constriction happening. Okay. And then the last thing is, what if we don't hear anything at all? What if we're listening to somebody's lungs, we get to a spot and it's just silent? That is what we call absent or diminished lung sounds, okay? This is considered a red flag. That means something is not right here. We should hear at least one of these things, but if we hear nothing, we're thinking something's seriously going on in this lung area. What could be happening? Well, we think that for some reason air is not moving at all. And there's two kind of more common culprits. It's either there's already air in there, and so there's no ability to move any more in there, and that would be kind of your pneumothorax or severe emphysema, where they are so full of air that they can't actually get out, that no more air is coming back in there. The other thing I think of is heart failure. If we have somebody whose heart is not working, we're getting a backup of fluid into the lungs now, and those lungs, they're not able to exchange any air. We have moved beyond our rails and crackles into the fluid is so high and so dense that air is not able to push that fluid out any longer to make the crackling sounds. We are now not hearing anything. Okay, so these folks, we need a chest x-ray right away to understand this, and probably sending somebody off to understand what is going on. Okay. If you're working in a primary care setting, that is. If you're in the ED, you're going to handle this. Okay. One thing that is really important, just a little pro tip, if you don't hear anything, you should ask yourself, do they actually have lung tissue in this area? The biggest mistake I've seen people make is they're like, hey, Morgan, I went and I listened to this person's lungs, and down in the right lower lung, there's no air movement whatsoever. And I say, okay, well, let's look at their history really quickly. pull up their surgical history, and sure enough, they had a lobectomy. And so they don't have any lung tissue there. So just always ask yourself, is there lung tissue? Should I hear something down here? And just ensure that they haven't had anything or they have no congenital thing going on that would indicate why they don't have any lung sounds down there. Okay, I know that seems obvious, but just wanted to go over it. Okay, one more quick review here of our lung sounds. So we have the crackles or rails. All right, that's your wood burning fireplace, your Rice Krispies popping fine course. That's some fluid down in the lower bases of the lungs, generally where we hear it. We think of pneumonia, bronchitis, COPD, stuff like that. Bronchi, I think a little bit higher in our larger airways. This is mucus congestion happening there. That's that low pitched kind of snoring sound that's occurring in those things. More of the high-pitched musical sound, we go into wheezes, airway constriction, asthma, kind of our biggest thing. Stridor, remember, a very similar sound to the wheeze, but we're hearing it up in the upper airway. So we're thinking of something that's causing airway constriction in the upper part, and that is foreign body, somebody's choking on something, croup, smoke inhalation. And then finally, that diminished or absent. So we're not hearing anything. We're full of fluid or we're full of air already. Okay. All right. So another type of exam that we can do are the pulmonary function tests. Okay. This encompasses a lot of different types of exams that can be performed, typically within a pulmonology office. So in a specialty office, they can offer a lot of different things. In primary care, we can do a simple test called spirometry, which I'm sure you're all familiar with. You may or may not have seen this. A lot of offices stopped doing spirometry during COVID, and I know that a lot of them are a little bit slow getting it back up and running. But this is a simple test. We'll talk about it here in just a moment. But when we think of PFTs, we think of how well are your lungs working. We assess lung capacity, airflow, the gas exchange, okay? We can do the spirometry test to help us differentiate things like asthma or COPD, and then it can help us kind of progress chronic disease progression over time. Okay, so a couple other things we use the bronchodilator test. So we can do spirometry pre or post with the bronchodilator. We can assess for that diffusing capacity of carbon monoxide. That's a very specialized test that you'll do if you decide to go into pulmonology, which is kind of a cool subspecialty of its own and lots of fun tests. And you'll get so good at interpreting all these things if you decide to go that route. And the volume flow loops is something you're going to hear. Just like, what does it look like, their flow loops on spirometry? And so we'll talk about that here in just a moment. All right, so jumping in here, spirometry, it's kind of a lecture in and of itself. There is so much to understand, and we don't have enough time to go into how to interpret each thing. But I wanted just to review kind of those terms that you will see on a spirometry test and you may see on your boards, just to give you a quick refresher on what some of those terms and those acronyms stand for. Okay, but it's always a good idea to go ahead and refresh a full spirometry and understand how to interpret these things as you go. Okay. So spirometry, something we can do in the primary care setting. Okay. If we have a patient who's coming in, let's say a 10-year-old who comes in, mom's kind of worried. This kiddo's had this like kind of dry hacking cough. Just doesn't seem to go away, kind of gets worse in the winter, maybe during allergy season. They've had eczema since they were a baby, they have seasonal allergies, and most recently they're waking up in the middle of the night telling their mom they just feel like they can't quite catch their breath, or that they can't breathe very well. We're suspecting some asthma. We have an awesome lecture on asthma, and I really want you guys, you can find it on our YouTube or tune into one of our webinars just to talk about asthma, as it's such a big topic, and treatment as well. But if this kiddo comes in, this is something you could easily do in your clinic just to kind of get a baseline, okay? So What we see here are these different signs. So we have the FVC, which is the forced vital capacity. So we have our patient take a deep, deep breath in and then blow as hard and fast as they can out. Okay. And that's the total exhaled volume after maximum inhalation. Usually we'll do a few of these tests just to get the best reading. Okay. So we don't take the first one, we make them do them a few times. Then we go into the FEV1. So this is how much air is blown out in the first second after they inhaled all of that air. They blow as hard and fast as they can. Then we measure how much is blown out in that first second. You're going to see it go up and then it's going to go down as the effort kind of decreases and the air has started to move out. Then we look at the ratio. So the FEV1 over the FVC ratio is kind of a key here into COPD. So this is kind of what we'll look at when we're thinking of COPD, okay? With spirometry, we can really understand, is this a restrictive or an obstructive type of condition happening in our patient? And, after we do this, depending on their results and what we see, we might decide they need a full pulmonary function evaluation with our pulmonology friends. So it's still okay to take these out. All right, so if we see somebody with a decreased FVC, we need further evaluation. We really think of like, this person is really unable to get a lot of air out. So we wonder, is there some restriction kind of happening? With asthma, we're going to see that the FEV1 is a marker that we look at a lot here. And what we see in the FEV1 with an asthmatic is as the disease or as the symptoms are worsening, our FEV1 is going to decline, okay? And then we give them a bronchodilator, a little albuterol, have them repeat the test, and we see this go back up. And as we monitor progress over time, that FEV1 will remain stable when we have really good control of their asthma. Okay, and then the FEV1, the ratio here, this is really what we look at when we're thinking about COPD. A person with COPD may respond a little bit to an albuterol inhaler, to that pre and post bronchodilator test, but maybe not. And so it's really hard to fully diagnose based on just this. However, if we also just think about our history and the person sitting in front of us and what are their risk factors and what do we most likely think is going on in their lungs based on what they've been exposed to and what other concerns we have. Okay. We also look at the flow volume loop. So you're going to see a change based on restriction and obstruction. But that's something that you can kind of look up and we'll go from there. Okay. So anything abnormal, if you feel really confident it's an asthma diagnosis, they respond really well to that pre and post bronchodilator, it fits the clinical picture, you can go ahead and monitor, start the inhalers. Do they need an IC? Like they're the inhaled corticosteroid based on their presentation, and they're following the steps for asthma treatment. You can go ahead and look on that. And again, check out our webinar for that. Okay. All right, now moving on to an acute thing, pulmonary embolism. This is very, very, very important to recognize and get out of your primary care office as soon as possible. We do not monitor or manage pulmonary embolism in an ambulatory setting. This is an emergency because it can progress and lead to death very, very quickly. This is an ambulance call. Okay, so a PE is formed usually from a blood clot, or from like a DVT. So think about what are the risk factors that my patient presents in front of me. This kiddo comes in, or this person comes in, they may have some chest pain, some shortness of breath, coughing. They may be coughing up blood. They may have more just diaphoresis, but typically these people are sick appearing and hopefully they're not coming to your primary care office at all. They're going straight to the emergency. So if you are in the emergency room, this is your job to take care of these people and order the correct tests right away and recognize this. All right, these people usually are pretty ill appearing, and the gold standard here is going to be ordering tests right away, like a CT, pulmonary angiography, is kind of the gold standard to visualize if there is a blood clot right there. Oftentimes, the radiology tech is going to be calling back to the emergency department because they're going to recognize it if it's large enough on, and then we got to get things going right away because the clock is ticking and these things can go bad really quickly. Okay. We think about treatment, it's the thrombolytics that we initiate right away. They can do surgery, like an emergency surgery to remove the clot, kind of depending on what they decide. But let's think about the risk factors here for a moment. Okay. Somebody who has a PE is at a hypercoagulable state. And the question is, why? Okay. So think through what puts somebody at a risk for hypercoagulable state. Have they had a surgery recently? If they've had a surgery, they're automatically at a high risk for clotting because most likely they're laying in bed, they're not doing much, the body's been under some stress. And so everything kind of puts them at risk. If they've been in bed for a while after a hip replacement or something like that, we always think, is it possible that they're now throwing clots from a leg or DVT or an impaired or a surgical site up? Other things to think about. Is there any family history or personal known history of a clotting disorder? I think oftentimes about factor V Leiden. Do these people automatically, we know this, so we're ordering these tests right away, telling them to go in. Other things that put you at a hypercoagulable state, atrial fibrillation, cancer, obesity, any autoimmune diseases, lupus, rheumatoid arthritis, pregnancy, that kind of thickens their blood. And then something else to always remember is hormone use. This could be both testosterone use or estrogen use. So I think of a kind of an unfortunate event when I was attending school at the University of Washington. We got news of a 21-year-old woman who was walking across campus, seemingly healthy, who collapsed. And she was taking a birth control and was a current smoker, which increased her risk of developing a pulmonary or a clot, which then unfortunately traveled to her lungs and caused her untimely death. So think of all of these risk factors when you're going through and thinking about what could possibly be here. All right, since we covered this, now it's my favorite time, which is quiz time. I'll give you a moment here. I'll read to you these and give you a moment to answer. Okay, so a 54-year-old male presents to your office, unfortunately, with an acute shortness of breath and a sense of impending doom. Oh no. All right, he had a right knee surgery 1 month ago, total knee replacement, returned, and he was in the car for a long trip. All right, his medical history, not great. He has hypertension, dyslipidemia, metabolic syndrome, and he's on the following medications. He does take an aspirin daily, good thing, and amlodipine, atorvastatin. He drinks 2 alcoholic beverages a day, but he smokes 1 pack of cigarettes since his late teens. Wow, lots of smoking. After surgery, denies illicit drug use. His physical exam's pretty normal, okay? And you suspect a pulmonary embolism. All right, what diagnostic test would you likely use or order to rule out this diagnosis? So go ahead, you can put your answers in the chat, write them down. We have D-dimer, we have a chest CT with pulmonary embolism protocol, the ventilation perfusion scan, or an ECG. Okay, if you answered that B, the CT with the pulmonary embolism protocol, you were correct. That is the gold standard. Now, we do have other tests that we can do. So if you answer the other ones, they're not incorrect, but B is going to be the best answer, okay? That's the way these boards work. They're going to kind of try to stop you up. So if you ordered a D-dimer, absolutely, that's great. It can help you think that you're headed in the right direction, and it will oftentimes be ordered in the emergency room. I don't ever order a D-dimer in primary care. I know a lot of people do, but if I'm not suspicious of a clot, I'm sending that patient off anyways, and I assume they're out of my office before I have time to do blood draws, okay? If these people are presenting in this way with this history, I'm not getting the labs. I'm sending them probably in an ambulance or with somebody else to drive them directly to the emergency room, depending on how their vital signs and stuff are looking. So the D timer, order it. If you are in the emergency room, you will always order it. Primary care, you'll see different practices around that. Choice C, this is the ventilation perfusion scan, also known as the VQ scan. So we do use these in patients who can't, for some reason, get a CT, or they can't get the dye for a CT scan. Okay, so this is also not the wrong answer. However, it's not the gold standard. This is something that we don't use as often, only in people who can't get the CT. An EKG, great answer. Yeah, I think you would definitely get an EKG. However, that's not how we're going to diagnose a pulmonary embolism. We will see changes, however, on an EKG. You may see that large S wave in lead 1, a Q wave in lead 3, and a T wave inversion in lead 3 together. It can just tell us that the heart is under some stress, okay? But it's not diagnostic of a PE. So something that the emergency room, they'll definitely get this, but again, not our gold standard. Okay, let's go into some infectious pulmonary conditions. We're going to start with COVID. It's common, it's out there. You guys probably know so much about COVID and probably are a little tired of hearing about it, as we all are, but it is still there and it's still causing problems. And we still need to be on the alert and making sure that we are taking care of patients and taking things seriously, especially depending on their vaccine status. So as you all know, this is a virus caused by the SARS-CoV-2 virus, and it's very highly contagious, okay? That's why we did all the masking and the social distancing and all of that back in 2020, 2021. But coughing, sneezing, talking, close proximity, those things all put us at risk. So something that we're doing in our clinic still is if somebody comes in and they're ill appearing, they have upper respiratory symptoms. We don't know at that point when they're checking in if they have the flu or if they have COVID or just a URI. However, we're masking and we're asking them to mask just to reduce the spread to anybody else that's in there. And, you know, we need to keep working. So we reduce the spread to us. We know that the masks do decrease some of that transmission of any type of virus so that they're protective, you know, whether or not we know it's COVID. When we really think about COVID-19, we think of a dry, unrelenting cough, okay? It's tough these days to diagnose somebody. It was easier before vaccines, but now depending on people's vaccine status, we may see that people have a variation of symptoms. And we saw that in the beginning too. However, I have a lot of patients. Just the other day, somebody said, you know, I had COVID in the past and I lost my sense of taste and smell. So I don't think it's COVID this time. And some of those things, they're just not quite as reliable. So we really do need to use our diagnostics to understand whether somebody has COVID or not. Because without a test, it's pretty hard to know, especially if we've been vaccinated and we've had it, then our symptom presentation may change from exposure to exposure. Okay. Some people, the range of illness really depends on personal risk factors that we don't know about and also vaccine status. We know that people can die or be severely made ill from this and hospitalized and put on ventilators. So I always tell people it is important to get those booster shots and stuff like that, especially my patients who are just at higher risk due to other comorbidities. So diagnosis, as you have all been made aware, is our swab test. We can also do PCRs, so forth. And we can use our antiviral medications. So if somebody does come in based on their risk factors, their current medications and so forth, you may choose to go ahead and prescribe Paxlovid. I know I used it more this winter than I've used it in the past, making sure anybody on a statin, that they discontinue their statin medication and so forth. And the reason I choose to use this, it limits their disease presentation. So they're just sick for a little bit shorter time and also can reduce the effects of long COVID. Okay, so things to consider. Our vaccines are very, very helpful in reducing hospitalization and death as well as long COVID. So really, really critical that we talk to all of our patients about vaccines. All right, moving on to bronchitis. You will see this more often than anything. I would say it's just so, so common. And it's really characterized by some inflammation that we see in the bronchial tubes. Okay, bronchitis, inflammation of the bronchial tubes. All right, this can be a viral infection like flu or a cold. Some people are just more prone to developing a bronchitis. So they get a simple cold and it just seems to go there and cause those bronchioles to just kind of swell up. And you'll know those patients and they'll tell you, I get bronchitis every year. And oftentimes they can tell you what helps them when they have this. All right, but we also need to think about this. We can see bacterial infections that cause bronchitis, a little less common, smoke pollution, or pollution. But usually it's just kind of a nagging cough that won't go away. Okay, it's that cough that just like it hangs on, hangs on, hangs on. Maybe they're producing some mucus. It might start to hurt when you're coughing so much. This is different than that pneumonia chest pain. This is that intercostal muscles that start to really feel like they're just working hard because that cough just lingers and lingers and lingers. And when you touch their chest, those muscles are sore. So that kind of cues you in to the chest pain that's different from a heart attack and different from pneumonia. Okay. We can have these acute symptoms. We consider acute less than 3 weeks. Okay, this is pretty self-limiting versus, and people may have a little mild fever. They might feel tired just because they're not getting great sleep, potentially some body aches, most likely a productive cough. We can hear some wheezing in their lungs because, again, we have that inflammation that is causing air to move through a tight space. So diagnosis is usually based on just our history and symptoms. If you're feeling pretty worried and you're thinking maybe this is a bacterial infection or could potentially get to that, you can always order a chest CT, CBC. I always am doing a lot of the flu-vid testing on patients, especially during the winter, just to make sure we're not missing a viral thing that we could maybe help them out with, depending on when their symptoms started, give them an antiviral. But usually it's just kind of self-limiting. It will go away on its own. Make sure that they're getting plenty of rest, hydration. I love giving patients Tessalon pearls. I think that really helps. Some pain medication if needed. However, if we're getting into that more chronic, so more than 3 weeks, this starts to get pretty unrelenting and patients are very done with it. So things that you can use for these folks would be like a prednisone burst or glucocorticoid burst to try to really get those lung airways to reduce an inflammation. An asthma or albuterol inhaler can help kind of open up the airways a little bit. Maybe you decide they need antibiotics, looking at their x-rays or CBC if the white count is up. So there's some different things we can do here for them. Okay, now the common cold. How do you know if it's just the cold? This is tough. It's something that every day I have patients come in and a lot of people have forgotten that these exist. It's either flu or COVID, and that's kind of where our minds typically go. And so you'll have patients coming into your clinic and they have what appears to be pretty mild symptoms. Their throat hurts, they're sneezing, maybe they have a little fever. However, we've got more than 200 of these viruses out there. It seems like this winter has been worse. I don't know if it has something to do with our immune systems and the fact that we did such a good job of kind of not getting any virus that maybe our bodies forgot how to fight these. But I've had a lot of patients coming in and telling me, I just have been sick a lot this winter, and it seems like more than in the past few winters. So who knows? But something that still exists. So just remember, these people are going to present pretty mildly on their physical exam. You might see some red swelling along the throat. They may have some clear or even some colored nasal discharge. So we no longer think that just because you have green boogers that you have a bacterial infection. However, a lot of people are going to ask you for antibiotics because they're really worried about it. However, we can go ahead and just rule out that it's not COVID, it's not flu with a simple test. That's totally fine to do, and I think it gives patients a lot of reassurance. oftentimes these people, they want to leave with something, they want to feel like they got something. So if you feel like you want to do a test, go ahead. Remember, pharyngitis or like a strep presentation just will be a little bit angrier, more red tonsils. Maybe you have some of that exudate. These guys, it just looks kind of irritated in the back, but you don't have those like really, really angry looking tonsils yet. Okay, colds can progress, especially in our immunocompromised patients. So I always give them, if things aren't looking better in 3 to 5 days, or if you get significantly worse, please come back and see me. Because things can move down into the lungs and cause more of a pneumonia type presentation. One thing that we have done is implemented a just kind of a pack. So when people come in and they want antibiotics or they want something because they feel they're just not feeling good, and you don't think that antibiotics are necessarily warranted, I use Teflon pearls a lot and also a little Mucinex. Those two things together seem to really help patients feel better sooner. And I write a prescription and they feel better leaving with that. So that's something that you can kind of put in your toolbox, the Teflon pearls for the cough, Mucinex, just to kind of dry up some of that findings. We use this. I know we're not talking about sinusitis. We talked about that in the past. However, we did a sinus pack for patients, which included a nasal saline, Sudafed if they didn't have any contraindications, and then Mucinex DM. And with those things, we saw the number of antibiotics decrease tremendously. And we only had, in the past year of doing this, we only had 2 patients who returned for an antibiotic for sinus infections. So it's really important to just reduce, have the antibiotic stewardship, making sure that we're not just giving out antibiotics because our patients are kind of hounding us for them, but we're making good clinical decisions and reassuring our patients that we're doing what's best for them as well as our entire community by making sure that we're using our knowledge and our clinical experience to determine whether an antibiotic is necessary or not. Okay, now pertussis. So this is the whooping cough, okay? This is something that's really, really serious in our babies and our older people. It's preventable through vaccination. So that's your Tdap and VEHAP for kiddos. But this is very, very contagious. I was just reading an article the other day. We have our vaccine rates are a little down right now. And I think it was 3 babies in Colorado that have died recently because of pertussis, which is really it's a completely preventable thing through vaccine or herd immunity. If we can just make sure that families and people that are around infants are vaccinated until they can get that vaccine. But pertussis is caused by a bacterium, the Bordetella pertussis bacteria, and it spreads through respiratory droplets. The symptoms really usually start out pretty mild, like a common cold, runny nose, cough, sneezing, and then they suddenly get worse. These patients have this extreme, uncontrollably coughing fit. So if you have a person in your office, you'll hear this coughing fit before you ever step in the room, and it is very, very identifiable. Go ahead and YouTube it if you haven't heard it. There's examples of a whooping cough so that you can kind of familiarize yourself with the whoop that happens during somebody who has this infection. All right, so they can, I think of babies oftentimes when I think of the whooping cough, and it can be so incredibly intense that the fit ends in vomiting and also central cyanosis. So if a parent is telling you that they're seeing the blue lips forming around their child's mouth after coughing, that kid needs to probably be hospitalized and supported with upper respiratory support, oxygen, and making sure that they're getting this. So we diagnose it using the PCR test, and then we treat with macrolides, okay? We'll also treat people within the family who have been exposed because it is such a highly contagious thing. We assume anybody living in the household also probably has this, may not be presenting with symptoms quite yet. However, again, I can't tell you the importance of the vaccine. The DTaP vaccine is in childhood, and then the Tdap booster. So Tdap has tetanus. I'm able to like update on annual exams. It's an every 10 year. A lot of people, they kind of forget when their last one is, unless they've been to the emergency room and had a cut or something like that. They probably haven't had it in a while. And then anybody who's pregnant or their partner is pregnant, I really recommend just getting an updated booster for this, just because it can be so incredibly devastating in babies and elderly people. Okay, chest x-rays. Um, this, again, another topic in and of itself, how to interpret and read a chest x-ray. I'm not going to make you guys experts today on this. It's a little challenging. So I'm going to really straightforward. My first job, I was able to see chest x-rays every day. So we had an x-ray machine in primary care, and we just would do wet reads on our own patients. And I've been at that clinic for 4 years. So I'm no longer reading chest x-rays, and I am not an expert in this. I am getting an impression from a radiologist, and I'm reading the reports, and I'm going based on that. However, radiologists do miss things, and it's important that, especially if you're looking to work in an urgent care or ED, that you look and you really learn how to read a chest x-ray. These give us a really good idea of what is happening within the lungs. So some things to look for. So here's our normal x-ray. Making sure you have a systemic approach of how you're reading an x-ray is going to be really important. And you can go online and look at just the different, where to start and go through and chest x-ray, and just familiarize yourself with that if you're heading towards more of those urgent care ED settings where it's going to be really, really common, or pulmonology where you're reading these on your own all the time. Okay, but just to some things that we would look for in pneumonia, you're going to see consolidation, which just kind of appears as this white stuff down here. You've lost kind of your costophrenic angle in the corner here. You don't have that sharp angle if you would see over here and down here. You see the stomach bubble here. You see the contours of the diaphragm, the heart, the cardiac silhouette. You can see lots of different, in a normal chest x-ray, some of the blood vessels, which is a normal finding. You're going to look at bone integrity throughout. However, in a person with pneumonia, you'll see some consolidation, most likely in the bases of the lungs. And then remember, tuberculosis would have some of those infiltrates kind of more upper that are really characteristic that you can look at. A pneumothorax, pretty interesting. So pneumothorax, you're actually going to see air not where it's supposed to be. So you have this darkening here, which is air in that pleural space, okay? So something just to kind of look at. It's the clue to a pneumothorax, and then we'll see a little bit of lung fluid surrounding the lung that caused just like a blurry effusion down here, or haze surrounding the lung. It can be hard to see this stuff. If you're not looking at chest x-rays all the time, knowing the nuances of a chest x-ray can be a little tough. So just lots and lots of practice if that's going to be kind of where you go. Okay, since we talked about x-rays, let's jump into pneumonia. Pneumonia is inflammation of the lungs affecting mostly the alveoli. Okay, so those little air sacs, that's where we're seeing them get filled with fluid as they become infected. And we have inflammation down there. Okay, there are different types of pneumonia. So we're going to talk a little bit about the most common viral versus bacterial, and then some of the atypical stuff that we'll see. Okay, so quiz time. The nurse practitioner is completing a physical exam on a geriatric patient with pneumonia. Which of the following would be expected on auscultation? We have wheezing, stridor, egophony, and then the mediastinal crunch. Okay, if you answered choice egophony, this is a test that we do. So we have the patient say E, and when we, over areas of consolidation, we'll actually hear, so as they're pronouncing the word E, we will hear it come towards an A. So that consolidation will kind of change the sound, and that can be very, very telltale of somebody with a pneumonia type presentation. If you said answer A, so wheezing, remember that's your narrowed airways. We see that more in COPD, asthma, bronchitis. Choice B, stridor, that's that same kind of wheezing, high-pitched sound, but that's in the upper airway. We think of more foreign bodies, croup, epiglottitis. So are things really swollen up in the throat? And then the mediastinal crunch is not pulmonary. So this is crackles with cardiac contraction. And you have to hold their breath to differentiate these sounds between is it coming from the lungs or coming from the heart? Okay. All right, so let's talk about pneumonia. This is pretty common. You're going to see it a lot in the wintertime. Again, we have vaccines for this stuff, so important to do. But most common things that we see causing it, you have your different pathogens over here, strep pneumoniae, and then the H influenza and mycoplasma. Symptoms can range, okay? People are going to present depending on how long they've been sick, and it can get to the point of sepsis. So you're going to see patients with a different level of presentation. So I think of cough, fever, and then that chest pain. That chest pain is different than the bronchitis chest pain. Remember, in bronchitis, it's more of those intercostal muscles that are really starting to hurt versus this deep, they can breathe deep and it just is like this kind of ache in the lower lungs potentially where it just doesn't feel good. I think that you can differentiate those two versus a palpation and different than a chest pain type pressure from like an MI or something like that. They're sick appearing, okay? So we want to make sure that we don't get these people don't go into respiratory failure. So if they're cyanotic and they're confused, they shouldn't be in the primary care office. We should have them sent again off to emergency for possible hospital admission. Okay, so on exam, remember we can hear that eugophony, we can hear the crackles or rails. Also, you can hear the fine or coarse crackles. Maybe we even in a more advanced stage, now their lungs are so filled with fluid, they're so inflamed that now we're not hearing much at all. And that's a more advanced stage of pneumonia. So what do? We can order chest x-rays. So a lot of times what in the primary care practice, what I will do is if I'm really like pretty sure this patient has pneumonia or they're at high risk of severe complications because of pneumonia, I will go ahead and treat and order the chest x-ray the same day and the blood work. So I'm treating presumptively, assuming that they have pneumonia. I'm starting them on antibiotics. I can always stop the antibiotics if, everything comes back totally unremarkable. And I'm like, hey, looks like you just have a bronchitis. We got it wrong here, but your chest x-ray looks fine. Your CBC looks fine. Everything else, it's better to take it away than like some of these elderly patients that I'm taking care of. I'm going to go ahead, if I'm concerned, I'm going to go ahead and treat before I actually have the chest x-ray in hand. So I give them both prescription and x-ray order at the same time. They go to health images or wherever and get that done. All right. Chest x-ray is the gold standard for diagnosing pneumonia. It will show us consolidation, potentially some pleural effusion. We'll see an elevated white count. Also, PCR blood testing, I don't do it too much, but you could. It can help confirm. That would be something probably done more often in an inpatient setting. But treatment wise, so something really important to understand is like as resistance is occurring, your treatment options may be changing. So I'm not that far out of school, 5 years, and we used to use Z-Paks for everyone with pneumonia. And within my first year, all of that changed. So now we use amoxicillin plus like a macrolide or doxycycline. So just always looking up what the treatments are, the best guidelines as far as making sure that you are prescribing what is the best. Okay. Then we have viral pneumonia. Difficult to distinguish between the two. What can cause these? You got it. It's like flu, RSV, adenovirus, COVID, can all cause a viral type of pneumonia. And viral pneumonia can progress into a bacterial pneumonia. So it's important to remember that. These people can, depending on their risk factors, can get sick and require antibiotics if this doesn't go, if this were to progress into something more serious. When we think of bacterial pneumonia, we think of it kind of being more of a quick onset, okay? Viral pneumonia seems more gradual. The symptoms in a physical exam, not quite as in your face, not quite as severe presentation, all right? You You can get a CBC, CMP. You can do all of your testing. So influenza, RSV testing, COVID testing, chest x-rays. You're probably going to get one because you don't know if like what's quite going on. Um, you may see some parenchymal defects that help you kind of confirm the diagnosis, or you might see a normal chest x-ray, okay? But the treatment is just kind of that supportive care. If obviously they're positive for COVID or flu, you could offer an antiviral to kind of help lessen the duration and the symptoms. RSV, we use the ribavirin, and then HSV or varicella would be treated with the acyclovir. Okay, sometimes we need that more. It's typically something we can treat at home. However, if your patient's sick, then we'll be sending them for oxygen, more supportive care. All right, atypical pneumonias, less common. We think of mycoplasma, the Legionella, chlamydia. It's hard to put kind of two and two together. So these symptoms are really similar, kind of milder. They can include just a headache, sore throat, maybe a non-productive cough. So we kind of dig deeper to further diagnose. So here it's like the PCR and serology tests, kind of the most useful to really understand what's causing this presentation. And treatment for this atypical is typically your macrolides or fluoroquinolones, okay? All right, so quiz time. One more thing. History and physical findings. Identify a case of a community-acquired pneumonia in an older patient. Which of the following can help identify if this patient requires collaboration for a higher level of care acutely? The curve 65 index, bronchoscopy, pleural fluid culture, or a chest x-ray? Go ahead and put your answer in the chat box if you're on with us on Zoom. All right, if you answered A, that is correct. So the curve 65, we're going to talk about here in just a moment, is a severity score that we use to determine mortality risk and decide if a patient can be managed in an outpatient or if they need to be admitted. And if they need to be admitted, do they need to go directly to the ICU? Okay, so we look at confusion, the BUN, respiratory rate, blood pressure, and their age. All right, we'll talk about it in just a moment. But if you answer answer B, not something that we do acutely, a bronchoscopy, just it's a study we use to look through the lungs, but not in a pneumonia acute case. The pleural fluid culture, that's going to be obtained through a thoracentesis, not available acutely. And chest X-ray is good to diagnose pneumonia independently, but it doesn't tell us if we need to send this person. We need to be looking at our patients, especially in primary care. If we think they're looking really ill and we're concerned about potential sepsis, we need to send them right away for an evaluation in the emergency room. Unless you're able to get stat labs in your primary care setting, a lot of this is going to be just looking and knowing how bad your patient looks, okay? So we have the curve 65. This is the indicator for severity and mortality related to pneumonia. And each one of these, if you answer yes to any of these, then you're going to give a point, okay? And then we take our points here and decide what's their mortality risk, and then where should they be in the hospital, all right? So if you're looking at a patient and they're confused and their mental health status is normally non-confusion, then that is, automatically probably buys you to be evaluated in an emergency room setting if you think they have pneumonia and they're confused. If you can't get the BUN in primary care, then you have to rely on some of these other factors, okay? However, if you have somebody whose respiratory rate's over 30 and their blood pressure is low and they're older, I mean, you now have 3 points here, okay? You're sending these people direct admit, probably in the ambulance over to the hospital, because look at their mortality, 22% mortality rate, but even with just 2 points. So answering two, so a little confusion, and over the age of 65, they have a 9.2% mortality. They need to be sent to the hospital for immediate care, all right? Okay, and then just a quick review on vaccines. So we can't overstate how important a lot of these things are preventable through vaccinations. We have, lots of complications from pneumonia. So we think of those that are very young, less than 2 years of age, or those older than 65. They can benefit from pneumonia vaccine prophylaxis, especially those with decreased immune function. So if any of your patients have any sort of autoimmune problem, HIV, cancer, sickle cell, getting treatment for different things, diabetes, if they have a chronic lung disease, liver disease, heart disease, these people need to be vaccinated. And having this conversation and just letting them know, we can prevent some pretty severe sequelae from these infections if we do vaccinate. We're not just stopping there. We have our annual influenza vaccine. A lot of people are hesitant to do that. There's a lot of hesitation around the COVID-19 vaccine. We know that it reduces hospitalization. We know it reduces death rate and mortality rate. We know that it reduces long COVID symptoms. We need to share this with our patients and continue to just let them know that these are available, and we do recommend them as the body and medicine and science. These things have proven to really help keep our community healthier and safer. And the more we all vaccinate, then we protect those who are unable to receive a vaccine for a different reason through the herd immunity. So if age or health status, puts people out of this, if the more people we have vaccinated, then we will definitely see an improvement. Okay, so that wraps up our day. Any questions that anybody has, please feel free to put them out there right now. We covered a lot of stuff here. I hope it was helpful. Okay. And then if there are no questions, I'm gonna just do another plug. So our 3-day review, it's coming up here at the end of the month, May 31st. We are getting all geared up to give you guys some great information. It's going to be a live session. But you'll be able to access the recording. It's $50 all 3 days. I think this is going to be really, really helpful just to get everything under there, ready for your boards exam. If you have any questions, go ahead and click talk to us, Rachel or I, and we're more than happy to help get you started on this day. Otherwise, guys, it was wonderful. Good luck on everything. Okay, and Michelle Chung has a question about smoking with vape pens now. All right, can you be a little bit more specific? What is your question regarding? I don't know, Rachel, maybe you can help me a little bit. If there's any great scientific data, implant with blood clots. So I would say with the nicotine, that's a great question. I think the nicotine would still, but then with the implant, you have progesterone and nicotine. I don't know that that's going to increase your risk as much as being on like a combined. So I think it's more of that estrogen based. I'm not sure. Does anybody else happen to know? Is there any more evidence-based data on the use of vape pens and birth control or contraception? I would say that if you're vaping and you're on an oral contraceptive that has both estrogen and progesterone, you're going to have an increased risk of blood clots because you have the nicotine in there with the estrogen component. So I would say that would increase your risk. However, if you have the implant, I don't believe that's going to increase your risk. So the implant is safer for somebody who smokes. I hope that answers your question, Michelle. Yeah, anytime. Thanks so much for participating and asking questions. I love it. Okay, guys, anything else? We have a couple more minutes to go through anything, any pressing questions? Right. Well, good luck, everyone, on your boards exam. It was so fun talking with you today. And just remember, you've got this. You know all of this stuff. And I'm so excited to see you out in the world as an NP. Good luck and take care. And hopefully, join us for the 3-day live review here at the end of the month if you haven't already passed your boards. Okay, take it easy and uh, Godspeed on this on your journey. Take care.